on.
But then we'll go ahead and get started soon.
Yo!
Hey, Dennis. I let you in first just to say hi. You're muted.
Perhaps I should unmute. That might help. Yeah, so...
What's up, Dennis?
What's up?
Well, I'm waiting to hear pearls of wisdom drop from your lips, Ranji. Are you...
Dude, I hope it's good. I hope people like it. I really want to pump this up. I want to pump Jessica up. I think it's going to be fun. It's going to be interesting. It'll be interesting for me just to hear what people are thinking, you know.
Mm-hmm.
I was telling Jessica, it's sort of finding that fine line being accessible and understanding without getting too much into the weeds. But this is the first time, so, you know, I've got to be sort of gentle on myself. So bear with me.
Well, we have your back, Ranji. Don't worry. Just think of it as talking to your students or talking to the wall or something. So how many people are signed up?
About 85.
Well, that's pretty good.
We've got 17 in the waiting room. So I think I'm going to start letting people in.
Okay.
If you're okay with that, Ranji.
Yeah, I'm okay.
Cool. All right.
That is really good to see. So, and by the way, you do not, you know how much you've been doing Zoom and work and stuff like that. Feel free to just do what you need to do. Just thank you, first of all, for just being here and supporting. So I really appreciate it.
Well, I just wanted, I just wanted to, you know, at least show up. I may not stick around, but I want to be there for you. So I think I'm going to go incognito now. It's about to start. I don't want to steal the limelight, Ranji. So
no, don't worry, man. You are again. Thank you for being here. And if you stay for the whole time, I'd be really surprised because.
Well, you just have to keep me interested. So
okay.
Yeah.
Okay.
So I'm going to mute and let you take it away.
Cool. Thanks.
Okay, man. Good luck. Break a leg. All
right, great. Well, thank you everyone for joining our weekly Ask a Psychedelic Scientist. So my name is Jessica Nielson, and I am the one of the co-founders of the Psychedelic Society of Minnesota. I'm also an assistant professor at the University of Minnesota doing psychedelic research and computational psychiatry research. And today we have a very special guest for our Ask a Psychedelic Scientist. His name is Dr. Ranji Varghese. He is, let me just pull up his bio. So he is a board certified in psychiatry and sleep medicine physician. He received his medical degree from the University of California, Irvine College of Medicine. He then completed his residency and fellowship at the Mayo Clinic in Rochester, Minnesota, where he served as chief resident. He is medical director of the Minnesota Regional Sleep Disorders Center in Minneapolis and an assistant professor of neurology at the University of Minnesota. He sees patients at his psychiatry and sleep practice. He has a clinical and research interest in substances that can induce non-ordinary states of consciousness as tools to understand the human mind and alleviate mental suffering. He is currently a co-investigator in an FDA-approved clinical study looking at the mechanistic underpinning of psilocybin at the University of Minnesota with myself. So we got FDA approval back in January, and we have submitted the protocol to the university's IRB. And so we're just sort of waiting for all of that to go through, and hopefully we'll be able to get started once the COVID-19 situation resolves. But again, thank you all so much for joining. I just want to give you a little bit of some ground rules and just sort of like an outline and format for how this will go today. So the way this will work is that we'll be asking, I'll be asking Ranji some questions that have been pre-submitted by some folks. And if anybody else has additional questions, please type them into the chat and we'll create a list of additional questions to field to Ranji as they come in. Any question is fair game. I will just say that we don't may have a policy of answering any questions about how to access illegal drugs, where to find underground therapists, or how to cultivate or make your own drugs. You know, we try to stay above ground. As the Psychedelic Society of Minnesota, we're really aimed at harm reduction and education and building community around psychedelics, but not providing people access to psychedelics. And we do want to keep everything that we do above ground and legal. Additionally, we have, you know, reputations on the line, myself and Ranji included, and other members of the Psychedelic Society who, you know, are working really hard to bring these things into mainstream medicine and society. And, you know, so we'd like to keep everything legit and above ground. So please keep that in mind when you're thinking about your questions. But I'd like to welcome formally Ranji to the group, and I'll just let you kind of do a brief little intro, and then we'll get started with the Q&A. So welcome, Ranji.
Hey, cool. Thank you. Wave if everyone can hear me. Okay, you can hear me. Thank you. And Jessica, it's Ranji Varghese.
My bad. I'm so sorry.
No, it's all good. No, it's all good. I actually do want to, I want to first start off by saying thank you to you for inviting me on. And then also thank you to you for putting Minnesota on the map for psychedelic medicine, not only for the research lab that you have at the U, but for sort of creating this little community for the psychedelics. And I think it has, I remember when it first started and seeing how it's sort of grown over the just a very couple of short years. It's been incredible. And so it speaks to the people that are here right now are just appearing. We have a whole underground of other people that are just not with us tonight. So it's like the mycelium, if you will, of mushrooms. But so for me, I'm going to just describe myself. I'm Ranji Varghese. I'm a psychiatrist. I'm a sleep medicine doctor. I'm an MD. I'm board certified. I have research interests. I've never formally, you know, had any research training, but I've been part of clinical trials and published papers. I see patients in my psychiatry practice and in my sleep practice, and there's a lot of overlap between the two. And I love what I do. I've been doing it for more than 10 years now, and I can't imagine doing anything else. And we'll talk about this a little later, but I think psychedelics are sort of, in my opinion, sort of, we're really lucky to be alive in this time right now, is what I would say, in terms of being able to potentially use these tools, these medicines, for understanding the brain itself, not only for understanding the normal brain, but really understanding the normal brain to be able to treat a brain that isn't functioning normally. And I put that in quotes. Well, dysfunction is really a dysfunction if it's causing a problem, right? So so we're really lucky to, one, be FDA approved, other groups sort of coming online, and people starting to dial into the potentialities of this of these substances, which, by the way, have not just been discovered. They've been around for decades and hundreds of years, and they've been used in shamanic rituals and in indigenous peoples. But we now in the Western community, apart, except for the fact that we had been using it up until the 50s and 60s, had been using them fairly successfully. But we lost 50 to 60 years of psychedelic research. We lost 50 years of neuroscientific psychiatric research because these medications were put on Schedule I list. So we're now inching towards being able to do legitimate studies, get them funded, and then perhaps really show the world what most people have known for a very long time. So my job, I hope tonight, is to sort of educate you. I don't really want to go into too much of the weeds with research. I'd like to maybe speak to about how I conceptualize how these things or psychedelics may work, and these mind manifesting medications may work. But what I can't do is this. I can't talk to you about, illicit drug use or tell you how to do that, right? That's just not my thing. I shouldn't, that's not legal. So I can't answer questions about that. And I'm employed by the University of Minnesota and other places, and they have nothing to do with my talk tonight. So I just want to make that clear, that what I'm saying is my opinion and what I've researched, so my opinions do not reflect my employer. So I've got to say that because it's fair game. I mean, they should know that I'm saying that for them as well. So I'm with Jessica in the sense that let's talk about how do we sort of explore these things, how do we push this forward. Let's talk about, maybe conceptualize how we think these things may work. Not just psilocybin, but maybe MDMA, and maybe other things. Maybe you'll educate me on things that I don't know, because this, again, sort of a nascent field. There's been tons of anecdotal research and research from the 50s and 60s that were not placebo-controlled trials or what have you. So with that, I'll just kind of let it go.
Great, thank you for that wonderful intro, Ranji. Ranji, saying it right?
Ranji.
Ranji, thank you. And I apologize for saying it incorrectly for so long.
Jessica, my two best friends that I've known since I was 11 years old cannot say my name correctly, and I've never corrected them, because it's just like, that's how they know me, and that's how I know them. So it's all good. No worries. No harm.
Okay, great. Well, thank you. So the first question I'll ask is, what do you feel is necessary for an effective psychedelic therapy set and setting?
So yeah, good question. So when most people, I'm sure, that are on this video chat probably understand what we mean when we talk about set and setting. When we talk about set and setting, we're talking about what is the mindset of the individual going into this particular experience, and what sort of environment are they surrounding themselves with to have a optimal experience. Now, I would add to this, and I would say this is where it gets tricky. This is where we need to become a little bit more sophisticated. And when we talk about psychedelics, is not only do we have to be very cautious about what the person's mindset is going into the particular setting or to the therapy, you have to understand what happened to that individual before they even got to your door and maybe considering psychedelics. So maybe the pre-mindset, sort of the static state of what the brain is at that time on a sort of a default mode. Then the mindset when the individual is at this space where they might start the therapy. So the mindset, is it nervous? Is it afraid? Is it angry? Is it hungover? Is it in withdrawal? All of those things are irritants to the brain. Like, are you sleep deprived? That's a stress on the brain. It's a stress on the system. So that mindset may not be optimal going into a therapeutic setting. It may alter it, and you may have a different experience than if you weren't in an optimal setting. But nonetheless, it changes what we think could increase the probability of something being a very good therapeutic experience. So I think the mindset should not only be free of toxins, I think it should be free of certain medications. I think that it should be free of certain stressors. If you have an angry fight with your boss or your spouse, or you're ruminating about something or worried about something prior to the experience, you may bring that into the experience. And again, it may be useful. You might use that as Irvine Yalom would say, grist for the mill. But you also may not be able to take full advantage of what that setting is. So what is the mindset at that time prior to going into the experience, physiologically and psychologically, and also the pre-mindset, the steady state, of the basal state of that individual, whatever they may have, personality traits or previous or comorbid psychiatric problems. The setting is all about safety. In my opinion, the setting is all about safety. Not only physical safety, but mental safety. This is why in research trials, you have sitters that are trained to understand when someone is having sort of a difficult experience, whether it might be anxiety, whether it may be an existential crisis, whether it may be a realization of some sort of trauma that they may have experienced, and now sort of looking at it again. Sitters are there to sort of ground the patient. And I like to think about it as, if you're on a trip, okay, if you're taking a trip and you're in the sky, you like to have contact with ground control. And the sitters can be ground control. You can sort of check in with the sitters, and you can sort of ground yourself to know where you are and what's going on, and see if it's okay. But you have to trust those sitters. And in order to be able to trust those sitters, you have to be trusting, but the sitters also have to communicate something to those individuals to enable that trust. Okay, so if you have a sitter that isn't sort of focused on you, that might be looking at their phone while you're having these experiences, you may internalize that as being not important to them, or something is going on. And so the sitter has to be appropriately focused, appropriately ready to give a hand if it's invited, to calm an individual if they're having a sort of a meltdown in terms of anxious response, but also to guide people, because when under the effects of these substances, you do have a little bit of physiologic changes too. Blood pressure increases, heart rate slightly, transiently increases. You might be a little bit lightheaded if you sit up and stand up, or stand up from a sitting position. So you want people there to physically be there for you and hold you and take you to the restroom and bring you back. So there's a lot to do with the physical safety and comfort of being in a place where you can trust the individual, and then and knowing fully that they have your back, both physically and mentally. You have to I believe, internalize that. And the individual that can internalize that these people here are here for me will, again, increase the probability that the experience may be better than not having that experience. So if you have someone, again, like I said, not paying attention to you or doing something outside of what they should be doing, it's not good. Now, what other things are part of the setting? Well, it's probably not kosher to be, again, hungover, or to sit in a position that may be uncomfortable for you. Or if the temperature is a little bit off, you might feel uncomfortable. Well, who cares about that? Well, just in the same way that when we think about mindfulness meditation or meditation, you want to find comfortable seated places, or positions where you're comfortable, places that you might feel comfortable, because they become, if you can eliminate potential stressors or irritants, you don't have to deal with that stuff invading into your mental space. So there's those, that's how I think about the mindset and the setting of the individual space. Whatever happens in between is individual. We can't predict it. We can increase the odds of something being good versus bad, but we can never be sure of that and predict it and know that that's what's going to happen. And I think that's why we have to be very careful, and we have to respect these medications. Yeah.
My bad, I was muted. That was great. Thank you. That was very thorough. So I'm going to move on to a slightly different question. It's something that, I think a lot of people think about and talk about, that kind of might be seen as an adverse side effect to doing psychedelics, hallucinogen persisting perception disorder. What are your thoughts on that? And do you think it has any links to things like psychosis?
So hallucinogen persisting disorder, HPPD, is by definition, it's part of the DSM-5 criteria. It's an experience that you continue to have visual disturbances or hallucinations or distortions in mostly your visual field. And this is all mostly visual experiences, trails or lights around or halos. And it may come, it may go, it may persist. We don't know what causes it. We know it's exceedingly rare. I have never seen one case in my entire career it's been 10 years, and I probably don't work in the emergency. I've actually the emergency psychiatry more often. It's really not something that I get too concerned about. And the thing about HPPD is you mostly have the visual disturbances, but you don't have the altered state of consciousness that persists. So while you may have these perceptual disturbances that linger over time, your mind is not disorganized or chaotic or in a state of flux that would be similar to what would happen in these non-ordinary states under the influence of psilocybin or any sort of 5-HT2A agonist. So it's links. So because it's exceedingly rare, you get a handful of these probably in the country, or I don't know how many you probably actually get, and people don't put enough research into figure out what causes it. And so we don't really know what if there's a correlation between that and then things like schizophrenia. Now, here's how I could conceptualize how HPPD could be distressing and could theoretically push someone over the edge. In no different way, in the same way that visual disturbances can be disturbing to an individual. They're going through their daily life and they're sort of distracted by these visual disturbances. Tinnitus is an example. Ringing in the ear is kind of an example of that, but it's an auditory hallucination. It's not an actual hallucination, but it's an experience that is distressing, and it can be distressing enough that people ask for help by their doctors, and they can get help, and sometimes the treatment is ineffective and we can't do anything about it. But what we eventually do is try and calm the patient down and try and take some sort of rehabilitative or palliative approach to saying, we get that this is happening to you. We don't really know what more we can do for it, but let's see if we can find ways of living with it and moving forward with it. So I don't know the answer to that, Jessica, in terms of if there are any causal relations or correlative relationships between HPPD and schizophrenia. But what I would say is this: we do not want to give, especially in research trials, and we have a lot of anecdotal data, but even with anecdotal data, you don't want to give psychedelic substances to people that have active clinical disorder that would upset them, or people with either schizophrenia or psychotic disorders or axis A disorders, and you want to you want to make sure that you're selecting for the right patient. I'll get to that point in just a moment, but I don't know the answer. I think that this is just sort of a residue of this chemical that is affecting visual cortexes and the parietal cortex, and it just happens to linger, and it kind of tells us that this thing changes your brain just a little bit.
Yeah, thank you for that. I guess I kind of want to expand on that a little bit, just for my own curiosity, and there are a few questions about this in relation to psychosis and why there are such strict rules, especially in the exclusion, criteria for a lot of these clinical trials to exclude people with a history of psychosis. Can you expand a little bit more on why that is and why it's so dangerous? And is there, because I've also heard from people that have schizophrenia that claim that it does help them. And so there might be outliers to this. And I think there's this feeling as psychedelics become more popularized and touted as these like miracle cures that people get excited about, and people with psychosis feeling left out. Why is it not available to them? It's really frustrating. So could you just expand a little bit on what the risks are there?
I think the risk is pretty clear. Psychedelics should be absolutely respected. They're powerful substances, not toxic, powerful. In fact, it has a very high therapeutic index. You could take a lot of it and nothing toxic can happen to your body physiologically, but it's potent and powerful. And what it is doing to the brain is, well, I'll kind of go into what it's doing. Most of the psychedelic substances bind to a receptor called the 5-HT2A receptor, or the serotonin 2A receptor. There are multiple different types of serotonin receptors, but psilocybin and LSD and dimethyltryptamine, they really like that 5-HT2A, and there's something interesting about that. But it binds, all these medications are promiscuous. It hits other receptors as well. And so maybe that's why you might explain some of the different sort of the experience that people have with LSD versus psilocybin versus dimethyltryptamine, et cetera. But I won't go into that. But the 5-HT2A receptor gets at it's binding to it, and primarily in the extrapyramidal cells of the cortex. And then what that does is it basically, what we think happens is this, what we call the default mode network sort of shuts down, and you allow these other connections that are sort of sitting at bay or not sort of necessary for normal everyday reality to be, for you to be functional and efficient in normal everyday reality. Those things sort of shut down for a while, and you get these associations between neurons that wouldn't normally communicate with one another, which is why people tend to feel a little bit more creative with these medicines, which is why people might experience memories or feelings that they haven't sort of tapped into, and they've sort of hidden in their subconscious, and now it pops up because these connections are there. It's just now you're allowing the defenses, your ego defenses, or whatever you're doing psychologically to push these away. You're melting those defenses to now allow these thoughts to be openly observed. Okay, but that can be exceedingly scary for people. It can be joyous and harmonious and spiritual, and people usually do describe the Hopkins study with Roland Griffiths in 2006 with people occasioning mystical experiences. 80% of people described using psychedelics as one of the 5 most important things of their life. Now, the reason why I say that is because most of it's positive, but if it's that potent, it means it's so potentially mind-changing. And for people that have schizophrenia, existing schizophrenia, their mind is not functioning in the same way that our minds are functioning. Remember, schizophrenia is a neurobiological disorder. It's a horrible disorder. It's almost as horrible as dementia, where you're just not able to sort of touch in with reality as well as other people who can be in touch with reality. They may have intermittent hallucinations that may be auditory, mostly auditory, sometimes visual. They may be paranoid. They may look into things and read into things that have no associations, but they find an association. In fact, psychedelics were thought initially to be a model for psychosis. So what happens is, if you have an individual that has coexisting psychotic disorders or schizophrenia, and then you add fuel to the fire, you could potentially increase the chances for them decompensating significantly. You may not change the outcome of their schizophrenia. It may not improve their chances. But Jessica, I'll answer one question. I'll answer this in one way. I would say is this. I have seen patients with schizophrenia that they know they have their hallucinations. They have awareness that there's a little bit of that they have some paranoia, and they can be aware of it, but they can't stop it. It sort of speaks to the sort of how neurobiologically wired schizophrenia is. It's complex. That's why we don't have treatments for this. So many different genes that are involved in this particular case. But those patients that have schizophrenia, who are sort of aware that they have these hallucinations, but are also depressed, who may be depressed because as a teenager they began to be psychotic, and they eventually develop schizophrenia. They lost friends, they lost relationships, they lost opportunities, and that depression and that despair and that despondency in psychedelic experiences could be re-examined in another light. So if this individual who has schizophrenia but has comorbid depression or anxiety goes into a psychedelic experience and says, whoa, I have schizophrenia, but I'm not a bad person. I have a neurobiological disorder, but people love me. That in and of itself may be healing, and they may be able to remember it coming out of the trip. And maybe that's how they say, my symptoms of schizophrenia are improved, or my depression got improved. But I don't advise giving this to anyone, especially in research protocols that have schizophrenia or psychosis to it, because we don't know what it does currently neurobiologically, nor will we anytime soon. We're getting there, especially with the things that you're doing in your lab and other people are doing in other parts of the world. But until we really have a good grasp of this, let's try and work with things that we know that it really works well with. And once we know how that works, then we can maybe sort of tailor it into treating other conditions. But boy, schizophrenia is one of those really, really wily, scary, destructive disorders that isn't going to have a one size fits all. Fortunately, psychedelics for things like the mood disorders and anxiety disorders, there's something weird about it, that it does have I wouldn't say one size fits all, but it seems to help a lot of things at once. And that's really interesting to me about psychedelics. So my answer is, you got to be careful, even if you don't have schizophrenia, going into some sort of these experiences. But for someone who's not in touch with reality in the way that we see reality, these medicines strip away reality altogether to a certain degree. You're just taking them farther and farther away from that plane of currently what's happening, and it may disrupt them. So that's how I would answer that question.
Do you feel the same about bipolar disorder?
Boy, again, bipolar disorder is one of those. Let's talk a little bit about bipolar disorder. We have bipolar disorder and we have unipolar depression. Unipolar depression and bipolar depression. Bipoles, two poles. Depression and the hypomania or mania, and then unipolar depression. They look like similar things, but they're really not. Depressive people with bipolar have really bad depressive episodes. It's melancholic type depressive episodes. It may be the same beast to a certain degree, but I think it's different than what we lump into the umbrella of what we call the depressive disorders. And on the flip side of the depressive disorders in bipolar, you have mania or hypomania or mixed episodes. In hypomania or mania, it's almost the opposite of what you have in these depressive episodes. Your mind is not hypoactive, and you have vegetative symptoms where you don't want to eat, you don't need enough, you don't sleep as much, and biologically your brain is just not functioning as optimally as it could, mostly because of serotonin. In hypomania or mania, the thoughts are erratic. They're disorganized. Most people will say they're disorganized. They may be going fast. They may make sense to people. They may be grandiose, but they can also be really impulsive. And those thoughts may actually not be rooted in their best, in their best interest or their family's best interest. So to give someone who in a let's say we give it psilocybin or the psychedelics to people that are having acute or hypomanic states, you're not doing them a service. You're not treating the underlying condition by treating mania. Mania is just sort of a condition that has to be modulated so you don't make any decisions that are horribly, horrific for the family. And we have good medications to take people out of mania. So why try anything else new that we don't have any good data for? But if you have a patient that has bipolar depression and that also that are in the acute midst of depression, there may be a role. Now, do we have other things that are helpful for bipolar depression? Hell yes. We have ketamine that's coming online. Ketamine is great for depression, or at least acute depression. It lifts people out of their acute depressive and suicidality early on. You need to have subsequent infusions to sort of keep that to have that longevity. And you have things like, I know people don't like to hear this, but electroconvulsive therapy. It is the best antidepressant that works immediately. It's been demonized by Hollywood, and back then we weren't using anesthesia and muscle relaxants, but I'm going to tell you something, maybe to get people quickly out of depression or even psychotic depression. We do have very good tools. So I'd say, why mess with something where we know we have some decent tools? Now, is this something for future research? Absolutely.
Great, thank you. Sorry, I was responding to something in the chat. So thank you, that's really helpful. I've been thinking about trying to summarize what we currently know about the relationship between psychosis and psychedelics. And I know Franz Wallenweider's done a lot of work in this area. And it's just, yeah, you're right, it's a big mystery. And I also have a pure schizophrenia project that I work on with the department chair at the U. And it's fascinating and terrifying. And I wish there was something like psychedelics, that could help, that could be so transformative the way psychedelics have been. But I think you're right, we just don't know enough about the disease or the drugs to know how they could pair.
Yeah.
Or rather that they shouldn't pair.
Yeah, again, a disclaimer, no one is advocating the use of any of these things for things that we have treatments for. We have good treatments in psychiatry. They're not this. Well, I'll sort of speak on how I think about medications and the role of antidepressants, if that's okay, Jessica.
Yep.
I've been a psychiatrist. I started my training in 2004, June of 2004. So it's more than 15 years. And And what I've seen over the years are that antidepressants are life-saving. Anticonvulsive medications or anxiolytic medications or mood stabilizing agents are lifesavers. But what I've seen is that the sort of where antidepressants sort of fall short is they may dial down the noise of the symptoms of depression and anxiety. They may sort of quiet them down so that you're better able to handle things and maybe make decisions that may be appropriate so that you move out of those particular training of thought. But it doesn't really solve the problem. It doesn't really get to the problem. It may mask things, and I'm not saying that isn't a bad thing. We need to. There's so much suffering in the world today that SSRIs do a great job of just sort of dialing down that experience of suffering. But now the question is, if you've dialed down the volume of that suffering, what are you going to do with that? That's where I think the medicine and psychotherapy come into play. You can treat depression with psychotherapy. There's no doubt about that. What is actually happening in psychotherapy? You're with a person that you trust, that you're sharing your inner experiences with, and hopefully you can remember things or have emotions that get you to a space where you can resolve conundrums. But it takes so damn long in psychotherapy. Who has 5 years and $300 an hour for psychotherapy? And I mean, it's true, right? I mean, not a lot of people have that. But but you can treat things with the depression and anxieties with psychotherapy. You can also treat anxiety and depressive disorders with antidepressants, and both of these together work synergistically. Antidepressants alone, however, I don't think they actually fix the problem, but they may give you enough headspace to be able to think about those problems back in the past without you being flooded by them. I'll give you an example: PTSD. Now, PTSD, we have really bad PTSD. It's very, very, very difficult to treat. But with some forms of PTSD, mild to moderate, the SSRIs are very good at addressing them. Now, how? Because in PTSD, you've got three sort of components. You've got a hypervigilant state where the body's in a fight or flight response. You have people that have this sort of, they engage in avoidance behaviors. So they don't want to re-experience the trauma or triggers of the potential trauma, so they avoid the behaviors. And so what these antidepressants are doing is that you're not flooded with the emotions as much. You're sort of blunted by having these emotions constantly putting you on edge to not be able to do the work, which is to expose yourself to the trauma. So the real work in PTSD therapy is prolonged exposure therapy. That makes sense, right? If I'm afraid of spiders, the thing if I want to get over if I want to get over my fear of spiders, it's not to confront a tarantula, right? And hold a tarantula. I'm going to be re-traumatized. But if I start thinking about a spider one day a week, and then maybe one day I see a picture of a spider on my computer screen, a couple of times a week, I start to get comfortable with the idea that these things are there. And I expose myself to that fear. And eventually I can get closer and closer that it's not going to affect me that much. But if I'm freaking out all the time because I'm on high alert and I avoid fear, engaging with the things that are afraid, I'm not going to things don't get resolved. But antidepressants can dial down that noise so that you're able to engage in psychotherapy and then work through those fears and eventually and hopefully resolve it. Now, this is the role where this is what MDMA is doing in the MAPS studies, right? So you've got this body of work that are done with really good researchers, and what they looked at are people that had treatment-resistant PTSD, okay? These aren't people that just had a failed trial of Zoloft. I shouldn't use the name of the medication, but anyways, an SSRI. But a failed trial of this. They've had failed trials of this, that, plus psychotherapy and so forth, and they have not gotten to where they needed to be. However, MDMA in the MAPS trials shows that 2 to 3 high-dose MDMA sessions. We're talking about 80 milligrams or so. Again, I'm not endorsing these things, but what they found were these treatment-resistant PTSD patients were not recovering, and I bet you it's because they were unable to do the hard work and be able to expose themselves to the fear and then resolve the fear. So where does MDMA come in? Well, it reduces the fear response. It automatically just shuts off the fear response. You have this amygdala that's firing like crazy, and your prefrontal cortex that isn't sort of trained enough to be able to keep it into shape. You know, your ego is sort of like normally sort of keeping fears and things sort of in the distance, but the fear response, that primal fear response, is overcoming that ability to shut that fear down and say, this is not a real fear. But MDMA shuts down the fear response. So then in the experience of MDMA, you're able to perhaps go back to that trauma. Let's talk about maybe a woman who was assaulted. She does not want to talk about that. Why would you? Why would you re-expose yourself to that? But maybe under those, in MDMA, if you're feeling comfortable, you might be able to think about it again and experience it in a way that you can resolve it and be healed from it, and to perhaps heal from some of the guilt and shame that go along with the trauma that happened. So there's a lot of things that happen in these non-ordinary states of consciousness that we don't really know from a biological neural substrate, but we know it's working. So it's a big black box, and that's what's really exciting about this. I don't know if I answered the question, but I just kind of went off on a tangent.
No, yeah, you did. And you actually touched on a follow-up question I had about the relationship between psychedelics compared to SSRIs. So that was helpful.
Okay, yeah.
Yeah.
Yeah, they work very differently. But listen, I mean, here's just for education. What are the SSRIs doing and the antidepressants doing? We used to have tricyclic antidepressants, great drugs, good medications, okay? We found it by accident, but they were good. But they were dirty. They're very promiscuous. They would hit the norepinephrine receptor. They'd hit the serotonin receptor. You'd have cholinergic activation. That's why people have side effects in the morning. So, and if you overdosed on tricyclic antidepressants in a depressive episode, it can kill you. Okay, I mean, that's why they were good, but they took it's not the antidepressant of choice any longer, because it really has a low therapeutic index. Too much can kill you very quickly. Now, SSRIs came onto the market in the 80s, and you have this really high therapeutic index where you needed a lot to kill you, but it kind of was almost as efficacious as the tricyclic antidepressant. So we then adopted these medications. They had their uses and roles. But what the SSRIs are doing is they're basically binding what we think to the serotonin reuptake transporter, a protein that vacuums up any exogenous sort of serotonin laying around in the synaptic cleft, or the little space between the presynapse and the postsynapse, or the communication bundle, if you will. And it sort of sucks it up. It blocks the reuptake, right? So it blocks the reuptake. So you have a flood of serotonin. You have a sort of an increased amounts of serotonin. That's kind of how they work. And that's kind of how MDMA works. It not only just binds to the reuptake, the transporter, but then it also secretes serotonin, floods the system by having the vesicles sort of bind to the membrane, and floods the system with serotonin. But again, remember, this is what's interesting about psychedelics, that even though the SSRIs, they're binding to serotonin receptors, there's a ton of serotonin receptors. There's the 5-HT2A, there's the 5-HT1A, 1B, blah, 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 and there's a bunch of them, okay? But psychedelics like psilocybin and dimethyltryptamine and LSD largely and selectively bind to the 5-HT2A receptor as an agonist. It's not just sort of flooding the system with this basal level of neurotransmitter serotonin. It's binding to this particular neurotransmitter and creating a different change in the way we're thinking immediately. That's what's really interesting. So the antidepressants take about 2 or 3 weeks for people to actually get a benefit, people to start noticing that they're getting better. The psychedelics, you have an immediate response. So it's working mechanistically in a different way. And that's what's fascinating. So from a neurotransmitter level, it's working differently, but on a network level, it's also working very differently. I think Carhart Harris and a couple other people just published something about the coupling between sort of neurotransmitters and large brain networks. We have form and we have function. So where does this particular form of the 5-HT2A receptor result in this functionality of the brain? We don't really know at this point, but once we because it's a black box to a certain extent, once we get closer to understanding that, then we'll be able to get even more sophisticated by tailoring things to that, I believe. But there, yeah, that's just a little lesson on antidepressants. So,
Go ahead.
What was that?
Go ahead.
No, I want to say this, that that's all. One of the other things that we need to be concerned about is that antidepressants, while they're good, they have side effects. By the way, let's talk about safety of psilocybin and other psychedelics. So let's talk about psilocybin, because that's the one that's mostly being researched right now. LSD isn't really, DMT isn't, because it has a lot of baggage that goes along with it, right? And that sort of baggage from the past, historical baggage. The psilocybin, again, safe. Okay. The toxicity of psilocybin is 1.5 times more toxic than caffeine. Okay, and we drink 100 milligrams of caffeine with a big 20 ounce of coffee. It is exceedingly safe from a toxicity standpoint. Now, from a, how it might change your brain or how you think about things, again, we need to be respectful of that. But what happens if you take too much of psilocybin or these psychedelics? Now, given that you're binding to a particular neurotransmitter, if something is overstimulated too much, that isn't a good thing. I mean, in anything, if you've got muscles and you sort of electrically stimulate a muscle too long, you result in the muscle actually atrophying over a period of time. It doesn't hypertrophy, it actually sort of reduces the firing rate of that muscle cell. And this can happen with neurons as well. If you overstimulate something too much, you can create at times, some toxicity and side effects. So theoretically, psilocybin can increase the chances for having something called Serotonin Syndrome. And that is a condition that has a spectrum of presentation. And what I mean by that is you might have mild serotonin syndrome to deathly, I'm in a delirium serotonin syndrome. And in between that, there's a spectrum of symptoms. It could be changes in eyesight. It could be changes in how your gut is motile, because we have a ton of serotonin receptors in the gut. It could be consciousness itself. And unfortunately, people that are on SSRIs may even have mild serotonin syndrome and not know about it, and maybe even more prone to having serotonin syndrome. Now, I'm saying that I don't want to scare you about antidepressants. They're exceedingly safe. Theoretically, psilocybin can also perhaps do that. What if you combine psilocybin psychedelics and another SSRI or a serotonin acting agent? You increase the chances for this thing called serotonin syndrome to occur. So while I say that again, these things are not, psilocybin is not toxic as other things are, caffeine, nicotine, almost as safe as THC. Combining these things with other things are probably not the best thing to do. And again, like I said about the mindset going into a set, if you have other things on board, it could be alcohol, THC, you change that potential experience. Maybe for the good, maybe for the bad, but it may not be as pure as it would be had you just, used it alone.
All right, great. Thank you. That was very, very informative. I really appreciate that. I know a lot of people kind of have these questions about the interactions with, or the comparisons with SSRIs. Do I need to get off my SSRIs? Am I in danger if they're still in my system? So I really appreciate that.
Yeah, Jessica Dennis and I are working on a paper for practitioners, for psychiatrists, to safely. We know that people are using ayahuasca, and ayahuasca is a brew that is commonly used by the indigenous people, the Shipibo Indians in Peru and the Amazon, and it's a sacred healing brew that has two components to it. One of them is dimethyltryptamine, and the other one is something called an MAOI inhibitor, but it's a reversible MAOI inhibitor. It's a fancy name for it's the vehicle that allows the DMT to actually get in through your gut into the brain. Okay, so this brew, this ayahuasca brew, is two real components: the MAOI, the one vine, or the vine, the Banisteriopsis caapi, and then the Psychotria viridis, which has a ton of DMT, or not a ton, but more so than some of the other plants. You brew them together, then it's sort of like a Trojan horse. The Banisteriopsis caapi, the MAOI, the caapi has the MAOI, allowing for the DMT in the leaves to essentially cross the gut and the blood-brain barrier to have these experiences. But I'm sorry, I lost track with what I was at.
You were talking about the paper you and Dennis are putting together.
Oh yeah, so we're writing a paper on how to, on what the potential interactions are with certain antidepressant medications and even over-the-counter medications, and giving psychiatrists and primary doctors a primer on, okay, I know my patient is probably going to do ayahuasca, or they told me that they're going to go to Peru to have a ayahuasca retreat. Okay, that's fine. But we want to make sure, again, like you said earlier, harm reduction. How do we get people to do this safely? And there isn't a good resource right now. So we're hoping to get this, published by the end of the year or something like that, and have that ready. But there's no real good way. So the safest way is to make sure that you're not using, I can't tell you to use these things, but in research trials, there would be a drug washout. And the drug washout time, or the period is the period that it takes for the active medication you're on, let's say an SSRI, to get out of your system. And that really largely depends on the half-life of the medication, meaning how long does 50% of the medication still stay in your body? If it's 5 hours, if the half-life of a medication is 5 hours, then at 5 hours after taking the pill or whatever it is, you'll have 50% of the SSRI in your system. Another 5%, you have 50% of that 50%. So you have technically 25%, and sort of exponentially goes down, right? So after a certain number of half-lives of this medication or the SSRI, you're safe to say that they're not appreciably in your system that would cause any problems. But people don't know this. And, sometimes even physicians are not aware of how to counsel people, which is, again, why I say you got to be safe. You have to know what you're doing. And I don't endorse the use of this without really sort of checking in with people. And not even that. I mean, obviously it's illegal, but you got to be sure and be safe when you're doing these things, because there are things that can go wrong. There are things that go wrong, but again, it's safe. These things are safe, but you just have to be smart about it.
Yeah, great, thank you. I think I'm gonna pivot topics a little bit.
Sure.
This came up a lot during last week when Dennis was on, and so you and I, this is in relation to giving psychedelics to adolescents, and so we have a co-investigator on the psilocybin study at the U. She's also she's a child psychiatrist giving ketamine to teenagers, and I think there's a lot of questions around what does that look like. Even like I think MAPS is expanding their MDMA protocol to treat teenagers with PTSD that the FDA is actually asking them to do so that they could show.
Wow.
Yeah. So I'm curious what your thoughts are for psychedelics for adolescents, I guess, both kind of as just normally how they would interact with a developing brain like that, and then maybe to stave off some major mental illness that onsets in adolescence.
Yeah, so a good question. The answer that I always give is, I'm not a child and adolescent psychiatrist. Catherine Cullen at the U is a fantastic child and adolescent psychiatrist. The work that she's done with adolescents and ketamine is awesome. And, it's very lucky because we've had precedent of using ketamine before in adolescents and children. In fact, ketamine is a dissociative anesthetic, and we used it a lot. It's a great dissociative agent. When a child is in a traumatic experience, maybe a broken leg, and the ER doctor has to set something, there's going to be pain, so you give an analgesic, but you also sort of just have them dissociate to a certain degree so they don't lay down these traumatic memories for the future. Sort of that's how it kind of helped to a certain degree. I don't think they intended that to happen, but that's what had happened. So we do have precedent that this agent called ketamine is absolutely safe, and we know that, and we've tested it in the anesthesia field. So we're able to pivot to the child and adolescent field and safely provide these without being too concerned about it. Now, ketamine and psychedelics, these are apples and oranges, and we know this. Ketamine is an NMDA antagonist or a glutamate receptor antagonist, where psychedelics work very differently. I don't think we have a lot of data to say that ketamine changes the plasticity of the brain in such a dramatic fashion as does the traditional 5-HT2A receptor agonist psychedelics like psilocybin, LSD, DMT. So what I would say is, given that children are already very sort of impressionable to the actual experience of what they may have in a trip, and given that a brain that is very plastic already can be made even more plastic, you potentially change the trajectory of this brain. And we just don't have enough data to say, hey, that's safe, that's good. Now, could I see a research protocol where I see patients that are terminally ill, including children? Look at some of the work that's being done in the terminally ill and death-related anxiety, and how psilocybin helps with that. Could you do that in the pediatric population where antidepressants are no longer going to be effective, and these children are suffering and they're being traumatized by being in the hospital and having to have IVs and blood draws? Is there a time when we can say, maybe these people who we know will probably die, but we don't want them to suffer, maybe we can give them a tool to alleviate that suffering, even just momentarily, and it may not harm them. And maybe that's the way we do that. That's again, could be, you'd have to go to an ethics board to make sure, does the child understand it? Do the parents understand it? Is this really worth the risks? I don't know. I want to drive home the point that because these psychedelics are so potentially create this neuroplasticity, in whichever way they occur, long-term by increased BDNF or brain-derived growth factors and so forth, the fact that you're sort of putting that growing brain on steroids, if you will, not real steroids, but the psychedelic steroids, if you will, I have caution towards. I'm sure there's precedent for it. I'm sure we have anecdotal reports about it. I would be even more cautious for youngsters. Even, you remember, the brain is still growing at 18, 19. We're starting to see brains still growing at like 21, 22. So we have to keep that in mind when we look at an individual. We have to individually look at these people. So I would say that you have to, if teenagers right now, I don't think should even be, I don't know. I mean, people are using this recreationally and not having problems. But from a research standpoint, I don't think we're going to get there until we're really absolutely nail down safety with adults first. I think there may be a role, but boy, I'm going to leave that to the child and adolescent psychiatrist. That's out of my wheelhouse, and I respect their work, and we'll go from there.
Yeah, I mean, thank you for that. I mean, whenever people say that, there's always the argument that in the Amazon, they give it to children. It's kind of part of their culture, and they don't see any issues with that. And, could potentially be seen as a rite of passage into adulthood to have one of these transformative experiences. But that's less of a clinical question and more kind of philosophical, societal, cultural.
But listen, what we're also talking about. If we were to choose people in these trials, we wouldn't choose normal children or adolescents, right? In these tribes, these children are probably not, maybe they're not suffering from depression or anxiety or psychosis like what we would be seeing. And they have these normal state brains, they have communities, they have families, they have sort of this surrounding care that is able to buffer them from these potentially frightening experiences. So Jessica, what a great point, that we do have precedent that children and adolescents and teenagers have used it. We know teenagers have used it because a lot of teenagers use it in the United States and elsewhere and not have problems with it. I just think that if you are using these substances in people with comorbid psychiatric illness, you have to be pretty damn careful about what you're doing.
Great, thanks. You touched upon something that kind of made me remember. So a couple of weeks ago, we had Raquel Bennett on, and so she's a ketamine therapist out in California in the Bay Area, and she was talking about how ketamine is really useful for things like ruminative depression, but not necessarily like active suicidality type depression. And then she was touching on trauma, and she felt that because of the dissociative nature of ketamine, that it really wasn't appropriate to treat trauma, because really you don't want people to dissociate while going through trauma therapy. But then you had mentioned, and I know this is kind of different context, but that if like to prevent the onset of a potential trauma because a kid is going through a traumatizing situation, like being hospitalized or whatever, that they would give them a little bit of ketamine to calm them down.
Yeah.
And so I guess I kind of just want to get
after the fact versus before the fact.
Right.
Trauma has occurred versus trauma hasn't occurred yet. Mm-hmm. And so that may be really different. I mean, this isn't dissociation in psychologically just a way of the ego's way of protecting ourselves, right? We don't want to be here in the trauma. We want to be elsewhere. The ego is saying, okay, I'm going to put the brakes on our current reality. I'm going to go somewhere else because this is way too scary and too traumatizing for me. So we dissociate. And unfortunately, the problem is the trauma continues and it's remembered elsewhere. It may not be remembered in a narrative fashion. It may be remembered emotionally. It may be remembered physically, how you felt. It may be, but it may not be remembered in that cognitive sense. So that's a really good question. I mean, I understand what she's saying is that in order to be able to resolve trauma, you need to eventually be able to resolve the underlying pinnings of that trauma. And in order to do that, you need to be able to expose yourself to those potential thoughts and fears and emotions and physical feelings. And dissociating yourself from that doesn't really get to solving that. But under the influence of, let's say, MDMA, you may, because again, the fear response is driven down, but you're also still cognitively intact to be able to recall things that you weren't able to, or you were suppressing, and now are able to come into your conscious awareness and work with it and process it in a safe way, biologically and with the sitters that you're with. So yeah, I would agree with that. I think I understand what she means when she's saying in trauma work, ketamine just kind of just numbs you out. Well, we do that, by the way, in other things, right? What do we do when we do this 8 hours a day? Or if we're binging on Netflix for how long? Or if we're drinking alcohol copiously or THC, we can, or psilocybin or recreational drugs that you use over and over and over and over again. You know, Richard Alpert, Ram Dass basically stopped using. He basically, I heard the phone ring. I picked it up. I listened to the message, and then I hung up. And I think this is how we should conceptualize the importance of these the psychedelics. Is that you don't need to do this to create some sort of new brain state. Then you're just chasing something, right? You're just trying to chase some sort of this altered state of consciousness, and maybe that's your thing, and that's what you want to do. But that isn't going to be helpful because now you're addicted to that. You get it? You know, people do this and kind of go, oh, I want to be in that state. Well, why do you want to be in that state all the time? You know, why isn't reality good enough? You know, it's not a judgment. I'm not placing judgment. I'm just saying that you can see people fall into this trap of going, well, I like doing this a lot because think about why that may be the case. I think the potential for these things is to have to revere these experiences, to respect these potential experiences, and learn from the experiences. Because the hard part of this trip is not the trip; it's what you do after the trip. The first step after that trip is the beginning of the journey, right? Because you've got to make decisions. Now you know all this information that you've technically downloaded, but you know it's not really downloaded information. It's really just your you're accessing information that was available to you, but just not available to you. You have so many filters on board to make your reality as crisp and clean and efficient as possible to be functional and efficient, that when these medications or these substances sort of take away those filters and allow you to think differently, thoughts will appear that you haven't been thinking about, and you feels like you're getting this information. Well, you already know it. Now you're just processing it in a certain way. It may do other things as well, but you get this information, and now the question is, what do you do with that? You have a different perspective now, right? You're able to say, I'll give you an example. I saw an episode of, I don't know if anyone else watches this show called This Is Us. I saw the first 3 seasons of This Is Us. I cried after every episode. So it's that good. I'm not watching it anymore, but there's one episode, it really stands out in my mind. And it was a scene where the boy, one of the sons, the middle son, confronts his mother. I think he's played by Mandy Moore. Mandy Moore is the mom. This is the TV show, right? If someone waved to me and say, yes, you're on the right track. This is the show. This Is Us. Okay, yeah, I got a thumbs up. Thanks, Matt. So the child had all this resentment towards his mom for the way she treated him growing up. But what he didn't know, this child, what he didn't know was in the background, the mom was protecting him from things that were bad. So in his mind, he just thought she's mean to me. She makes me feel, and that's how he grew up. And he continued to have this until, because he wasn't able to resolve that feeling that he had for his mother, right? And in one episode, he confronts his mother and says something, I don't even remember what it was, but she explains to him, wait, look at it from my perspective. Here's what was happening at the time. And then he goes into a situation where he remembers, and then he has a new perspective of that experience. It's like, oh, I see my mom as both sort of somewhat critical, but she also is a loving mom, a caring mom, a mom that gives conditional love. And so if you're blinded to that, if you have all these blind spots because you're moving through life, these substances can sometimes uncover you and allow you to see things in a fresh perspective. And now that you have a fresh perspective, you can do something about that. You can kind of come out of it, and people can kind of go, maybe mom wasn't so harsh to me. Maybe I can let that go. And there's something special about psychedelics. I think that not only are you recalling sort of experiences and seeing things in different perspectives, but the emotional catharsis that some people have under the influence of these non-ordinary states of consciousness is the catalyst, catharsis for that particular change, so you can better remember it. This happens in therapy too, by the way, psychotherapy. Some people have these wonderful breakthroughs where they just start crying and they can feel the emotion. It's just coming out. It's visceral. It's no longer intellectualization or rationalization. It's right there and it's palpable, and that they can resolve things. And so these substances are just catalysts. They just boost the system to be able to get into those states and do that work, and then safely come out congealed back to where you were to a certain extent, with that new sort of this new background, if you will, and this new data moving forward. What you do with it is what you do with it, right?
Yeah, great. Thank you for that.
Yeah.
I want to actually shift a little bit and ask you some of the questions that came in that were related to sleep, since you are also a sleep medicine physician.
Yep.
So how does sleep deprivation affect the quality of a psychedelic experience? Like, do you think there's any relationship there if you're kind of brain fatigued or haven't got enough sleep, and does that impact the efficacy?
Yeah, that's a good question. Let's talk a little bit about sleep first. I want to dispel the idea that sleep is sort of this on-off phenomenon, or this global whole brain phenomenon where we're on right now, and then all of a sudden a switch turns off and we go into this offline mode. That couldn't be further from the truth. Our brains are processing even when we're asleep. They're not processing like we do when we're sort of awake, memory centers are offline during non-REM sleep. There are other things that are, the neurons are firing synchronously and together and in a quiescent mode, and goes into sort of this sort of undulating rhythm. It's beautiful. And that's what we call non-REM sleep. Okay, so we have two stages of sleep. We have non-REM sleep and REM sleep. Non-REM, REM stands for REM, rapid eye movement sleep. Non-REM stands for non-rapid eye movement sleep. And they're very different. There's non-REM 1, 2, and 3, stage 1, 2, and 3. 1 is for sort of that light stage of sleep, that feeling right before you fall into sleep and you're in that little nether zone. Stage N2 is a little bit deeper. Stage N3 is like the Mariana Trench of sleep. Okay, you're sleeping so hard, sensory information is hard to get in to awaken you and arouse you. And if you do awaken, it's hard to come online immediately. And we all know this, right? If we're ever awakened in the middle of the night when we're in our deepest sleep, you don't know where you are. You're trying to make sense of what's going on. You're just starting to come online because the system has kind of sort of become quiescent to a certain degree. That's non-REM sleep. Now, REM sleep, very different and very interesting. And it's very active. The brain, the wiring of the brain, or the function of the brain looks very similar to a waking brain in functional MRI scans. Okay, so it's almost as functionally active while it's in this REM stage sleep, but it's different. Okay, we dream. We have our most vivid technicolor dreams in REM sleep. We do dream in non-REM sleep. It's just, they're boring. They don't have like a narrative. They're just sort of figments and fragments of thoughts. But REM sleep has this narrative to it. This has color to it. It has emotion to it. It's very different. So I think what I would say is that sleep serves a purpose, right? We spend a third of our life sleeping, 8 out of 24 hours a day. And that's a third of a day, and we spend a third of our life sleeping. That seems like a damn waste of time, right? I'd rather be binging on Netflix than, spending all that time doing something that seems so useless. But there's a point to it, because evolution and biology doesn't make mistakes like this. It's a very vulnerable state to sleep, right? I mean, our ancestors, if you were sleeping for 8 hours at a time, you could be vulnerable to the warring tribe or the saber-toothed tiger or whatever it might be. So sleep is serving some sort of a purpose. We don't know fully the real reasons why we sleep. There are a lot of competing theories. I think all of them are correct. There's the idea that sleep deprivation studies at least will show alterations in immune system functioning. Okay, so natural killer cell activity tends to be decreased. These sort of immune fighters, when you're acutely sick, these natural killer cell activity kind of comes into action. These things sort of go quiescent. They're not as active when you're sleep deprived. So immune system is one potential answer. Is it important for memory consolidation? The answer is yes. We're absolutely laying down memories that were during sleep. And we can prove it, because if I sleep deprive you as you've studied something, you're not going to recall something compared to people that were not sleep deprived. And similarly, if you took a nap immediately after you read something or had studied something, you will remember that thing better rather than if you didn't study. So memory consolidation and cognitive processing occurs not only during while we're awake, but this consolidation occurs. And that makes perfect sense, right? I mean, right now, I'm getting a lot of information from the outside world. I'm getting a lot of visual stimulation. I'm getting auditory stimulation. But that information may not be useful to me. But synapses are still firing as I'm awake, right? And we're sort of creating these new synapse forms. But that may not be efficient for me to be a functioning human being. So during sleep, the brain might somehow assign certain things that we're doing during the daytime to say, hey, that was really important. Maybe you should learn that and remember that. And so the brain consolidates that during sleep and during wake as well. So the brain not only consolidates information when we sleep, it also unlearns things that it doesn't think it should be learning. So these synapses that we think, or the memories that are tied during the day, or these experiences that we have during the daytime, the little dendritic spines and synapses that occur during sleep, and the synapses that are unnecessary sort of prune away. There's the synaptic homeostasis theory by Giulio Tononi and his colleagues at the University of Wisconsin-Madison, and they're doing high-density EEG work on that. So it basically means you can't continually learn things. There's only so much brain room or room in your skull to be able to fit your brain. You need to be able to be efficient and prune away these things, the pruning away theory. So as I say that, I'm making a big point that sleep is very important, boys and girls. But I'm also saying that when we're sleep deprived, we're not ourselves. The executive functioning skills, the part of our brain that's responsible for making appropriate decisions, to not be impulsive, to be able to reason through things, it's just not firing on all cylinders. And when that's occurring, you may make mistakes. It can also be freeing. Some people become disinhibited when they're sleep deprived, and that's freeing to people because they don't have that negative self-talk or that rumination that occurs. And in fact, what we see is in some people with one night of acute sleep deprivation can actually improve mood. Now, we don't know how, but my thought is that people that are ruminating depressives, okay, we used to call them the term that we used to use were neurotics, okay? People that had neuroses, people that constantly thought about things that were just, they couldn't get them out of their head. Not like an OCD sort of way of thinking about things, but just ways and patterns of thinking. Well, sleep deprivation can sort of shut that down to a certain extent because their executive functioning may be too sort of hyperactive. If you can slow that down by way of, let's say, I don't want to say slow that down, but if you're able to control it a little bit better, for instance, through mindfulness meditation, as one example, then you might not be so engaged with these different patterns of thinking temporarily. So acute sleep deprivation can cause these euphoric states, these disinhibited states, which may or may not make a trip, these psychedelic experiences, good or bad. It really depends on the individual. I couldn't tell you. But if you are someone who is really cranky after a night of sleep, you're stressed. And if you're physically and mentally stressed, that stress is going to be taken into the journey or that trip. And I that's when I would say, nope, you don't get to do this. You are not in a space where you get to do this. I have to make the decision as your sitter to say, this may not be the best thing at this time, right? So any stress, including sleep deprivation, can or cannot potentially enhance by way of increasing sort of the disinhibition or traumatize people because they're already sort of in this irritable state. So it's a long-winded answer, Jessica, to a simple question, but I think sleeping, eating, hydrating yourself, avoiding toxins, and keeping your mind, body, and spirit in sort of an aligned, balanced state increases the chances and probabilities for everything to work well. Not just psychedelic experiences, but everything. Relationships with your family, relationships with yourself. If you're abusing your body, if you're abusing your brain, if you're abused by not getting enough sleep or not eating enough or eating too well, you're stressing the system. When you stress the system physically, the brain it's all connected. So the brain will understand the stress, and you will have to take resources to deal with the stress that you've just created, right?
Yeah, those are great points.
Yeah.
I want to extend on that a little. There's a few things that were coming through the chat, and it's sort of related to some other questions that we talk about relating to dreaming and psychedelic experiences, and what is driving that. Like, is it endogenous dimethyltryptamine? Is it melatonin? What is going on when we're dreaming? Does it have anything to do with kind of how we experience psychedelic states? Do you have any kind of comments on that?
Yeah, I think it's really fascinating. No one knows. Okay, no one knows. But we do know that when the REM neurons are on, REM neurons are on during sleep and we're dreaming, acetylcholine tends to be the neurotransmitter that is elevated. Okay, it's acetylcholine, norepinephrine, serotonin, dopamine, histamine they're all excitatory neurotransmitters. When we're awake, they're on and they're doing their thing. When we're asleep, they go quiescent, including acetylcholine in non-REM sleep. But in REM sleep, acetylcholine comes back on, and we start to have this playground of dreaming. Now, what's different in dreaming, I think, and we all know this because we've all dreamt, I hope, and maybe some of us even have had the experience of lucidly dreaming, but it's really different than what people describe in a psychedelic experience. When I dream, at least, I don't know that I'm dreaming, do I? I don't know whether you know whether you're dreaming or not. We just happen to go through our dreams going, oh, look, that plane is flying overhead, or oh, look, I just jumped over this building, and it's just accepted, right? Right? I mean, these dreams are so fantastical and weird, but somehow in the dream, we're not going, what the hell is going on? This is crazy. What is this space that I'm living in? Because we're sort of naturally a subject within the dreamscape itself. We've not separated ourselves, our identity from the dreamscape. Now, right now, as I'm speaking to you, I have an identity. I know what I'm doing. I can change and manipulate my situation very easily. So this is a consciousness as we know it. But dreaming consciousness is different because you are not conscious of being conscious. You're just seeing the movie play out, and you may take part in it. The psychedelic experience, this non-ordinary state, is sort of this weird state where you have these fantastical experiences and maybe visuals and colors and recalling things from the past, the same things that happen in dreams, right? You might see people that you missed from the past come out into your dreams. Same thing in psychedelic experiences. The people that you may have memories of of people from the past. But in the psychedelic state, you're pretty aware that you're having a psychedelic state. Sometimes you lose track of that and you have complete disillusion of that, and you may meld into it, and that may be very concerning or disconcerting for some people. But the majority of people will know that they're in their body and they know what's going on, and they know that there's a disturbance in the reality that they're experiencing, right? There's the difference. There's a conscious awareness that consciousness has been altered, and it can be very disruptive. But if you can be, here's the other thing, is if you push against that, if in these psychedelic experiences you push against it and you want to fight against it and don't want to think about something, that pushback creates consternation and irritation and anxiety and fear, and it may worsen the experience. So the recommendations by most people is, if you're having a difficult trip or sort of a uncomfortable trip, I don't like to call them bad trips. In fact, we should stop using the word bad trip and start saying uncomfortable trip, because bad, because there's data that suggests that even uncomfortable trips, people get something out of them, even though they're uncomfortable. Even though you're in some discomfort, you might come back and go, well, hell, I did learn something from that, moving forward. So but that's, I think, the difference between, that's what I was going to say. What people have success in doing is, if they're in sort of uncomfortable states, is to just go with it, is to just sit back and observe and be a participant in what's unfolding, rather than trying to control things. That's advice that we should be doing in our daily lives, right? Things will unfold as they should. You have a choice in the manner with the control that you have. But the more you push against something, the more you want to force it in there, it's because there's some sort of drive or attachment that you have that is creating that. You gotta address that. So the more you're just easy and just go with it and just let go, that doesn't mean being passive. It just needs to take a intentional focus of just being with it and being okay with it. Yes-anding the system, setting boundaries, but yes-anding to yes-and the opportunities that sort of arise in these experiences and in life in general, So that's how I conceptualize dreaming and these altered states of consciousness. It's a spectrum, obviously, Jessica. Some people are on sort of the mild end, some people are on the other end, but I think there is a spectrum of it. The conscious awareness, the experience itself has its own sort of spectrum, but I think the degree of conscious identity is also on a spectrum as well within those experiences. And so the same thing in fantastical dreams, they may be very mild to very fantastical on a spectrum, and the degree of consciousness that people have within the dreams itself go from, I have no clue that I'm actually in a dream, I'm just going to do the thing, to, holy crap, I'm lucidly dreaming and I can control my dreamscapes.
Great, thank you. I kind of want to pivot a little bit to the topic of, I guess, insomnia and nightmares, and whether, because I know that that is a really substantial symptom for people with PTSD, and some of these, things like psilocybin potentially and MDMA could help with PTSD. And so what do you think is the role of kind of those sleep symptoms with nightmares and insomnia, and how could psychedelics help with that?
So nightmares are a near and dear sort of disorder for me in my sleep career, because I've been able to see people that are horrifically traumatized by their nightmares. If you are traumatized by your trauma, years ago, but then you have the same replicating trauma every night during your dreams, would you want to go to sleep? The answer is no. And so you can see how nightmares that are traumatic and that you probably know are going to happen and that you don't want to happen may lead you to behaviors of avoiding sleep. Or you may be so concerned and anxious that you may have a nightmare that your arousal system, the anxiety of having a potential nightmare, the anticipatory anxiety, will increase the arousal systems, the neurotransmitters that are responsible for wakefulness, okay? And that arousal system will overcome the ability of the sleep system to sort of take hold and get you into sleep. So you're overcoming. It's not like insomnia, by the way, folks, is a beast. It's a beast, and it's not a problem of the part of the brain that's responsible for engaging you into sleep. That the engine's okay. The sleep engine's okay. It's as if you have brakes on your car, and the brakes, you press the brakes to sort of slow down the system and go into sleep. What's happening in insomnia is that you're trying to press the brakes, but you're pressing the accelerator at the same time. Okay? So you're pushing and increasing the arousal system, and you're moving forward, or not allowing the sleep system to engage. And over time, people start to have these learned behaviors around sleep, sort of worries around sleep. I'm not going to be able to get to sleep. Or if they can't get to sleep because they're ruminating about something, they may start to become frustrated by the fact that they're not able to get to sleep. That frustration is a simple word for a hyperarousal state, a brain that is awake, which will be too awake to allow sleep to engage. But more importantly, if you look at sort of classical conditioning, Pavlov's dogs, for example, if you're in bed and you have a clock that's blaring at you, and you're awake and you're frustrated, you are getting frustrated while you're laying in bed, while you're looking at the clock. So all of those little things, the clock then becomes a trigger for your frustration. The bed itself, the bedroom itself, becomes part of the conditioned phenomenon. So this is the reason why people when they have insomnia, we tell them, go out of the bed, take away things that might remember the frustration that you have with insomnia, and relearn, sort of retrain your brain to learn that the bed is a place for sleep, and not to do anything around not sleeping, or any activities that it doesn't engage not sleeping. But with the role that I don't know. Here's how I can see psychedelics potentially helping people that are insomniacs or have nightmare disorders. Look at the PTSD papers. When we treat and effectively treat PTSD, we find that nightmares reduce. So when we get to resolving the problems in the hypervigilance, the sort of fight or flight adrenergic system, the adrenaline system, reduces, which decreases the autonomic adrenergic workflow or outflow of the brain, reducing the potential for nightmares. This is how one of the medications that we use for nightmares kind of works. It sort of binds to adrenaline receptors, if you will, for layman's. There's another way too, is just to treat the PTSD itself, to relive the nightmare, not relive it, but talk about the nightmare in a way that is not, scary, and re-exposing yourself to it, re-scripting the thing so you're not afraid of it anymore. And we do see nightmares decreasing. Again, it has to be done with a psychotherapist, and we call this dream image rehearsal therapy. But let's say that we can't treat the nightmares with medications and dream imagery rehearsal therapy, and we know that the nightmares are not due to some medication, or it's not due to withdrawal from substances and so forth, which it can be, or even certain antidepressants can cause vivid dreams and nightmares. What if the nightmares were associated with with trauma itself? If you're having these replicating dreams of trauma, and this is what people with PTSD have, they have replicating dreams of the trauma, and it's horrific. If you were, for instance, you had a tool at your disposal to treat the PTSD very quickly, for instance, MDMA as an example, in the MAP studies, what you see is decline of the actual traumatic experience as they think about it during the daytime, but you also see a decrease in the nightmare frequency as well. And I think they use the Pittsburgh Sleep Index to sort of track that as well. So there's quantitative data. And Jessica, I think we're using the Pittsburgh Index for our study too, right? Are we using something?
We're not measuring sleep at all, actually.
Okay, that's fine. I'm glad I mentioned it.
We could add it in later. I mean, if we're going to do a PTSD study, we'll definitely want to include it.
Yeah, exactly. This is a mechanistic study, basically. But so if we think about this holistically, try and stay a little bit away from too much of the details of which receptor is doing what, or what is doing what. We're not there yet. We know that what we do know is that it's creating a environment to be able, it's a mental playground, and you're able to manipulate things to a certain degree, but there are certain things that might come to you that you'll be able to think about in different ways, and then resolve within that experience through some sort of emotional catharsis, or maybe a cognitive catharsis, and then coming out of it and then making decisions moving forward on what to do to perhaps not make those decisions that maybe led you to a place that keeps you depressed, for example, or whatever it might be. Again, like I said, the hardest part is the first step in the journey after, I think, the potential psychedelic trip. So in that way, I think that these substances can be absolutely helpful. We just haven't done the research, and we haven't done it because, people are like, nightmares, who cares about it? But that's a big deal. The VA population itself, the incidence of nightmares in these people are more than 30%. Okay. And we know that even if you do treat PTSD with antidepressants and the daytime symptoms are improved, if you also don't fix the nightmares, they don't significantly get better. So we need to look at this alternate state of consciousness calling sleep as sort of we're doing something. So, and in the same way, maybe we could look at insomnia as a model. If you're engaging in behaviors that are not conducive to sleep, it might be looking at your phone on Facebook and raging against something that someone posted, or reading a particular news network and being angry about it. You in these experiences, you might start to see habits that are more healthy for you. Oh, I got to wind down maybe 90 minutes before bed from now on. Or, I don't need to do this, I don't need to rage against it. This doesn't matter anymore. These are peanuts compared to the real problems in the world. And maybe that might give you you might form habits that might be conducive to improvements on your sleep and so forth. So that's how I could see this being potentially helpful. But we have good treatments already for insomnia, and that's one of them is cognitive behavioral therapy for insomnia. It's not perfect, but it's useful. But I can see in these subset of population, this would be useful.
Great, thank you. That was so helpful. I know sleep is so, so, so important, and just kind of like impacts so many other disorders. If people can't sleep and your brain's just really fatigued and you're not kind of getting that reset, it can cause so many issues. It seems to be so crucial.
You know, when you know that term hangry, right?
Yeah.
Well, I get slangry. Okay. I get sleep angry when I don't sleep well. I get irritated, and it's executive functioning. This part of my brain is sort of like not modulating who I should be, and the real Jekyll and Hyde comes out, right? So yeah, now sleep is absolutely crucial, and I don't just say that. I do get about 8 hours of sleep every single night, and I have a routine, and I really value it, guys.
Thanks. So I want to pivot a little bit to, I guess, training and anyone that's sort of a therapist and interested in kind of how to become a psychedelic therapist. And so I know that, you know, there's all these training programs out there, and kind of, I guess I can have you riff a little bit on what you think is required to become a psychedelic therapist. And then in addition to that, in terms of the training, do you think it's necessary for psychedelic therapists to have firsthand psychedelic experiences in order to be a psychedelic therapist?
Great question. I think, oh man, that is really, really good questions. Well, there are ways of there is the CIIS in San Francisco that has a certificate program where they teach you sort of the nuts and bolts of psychedelics and sort of the components of psychedelic therapy. It's not recognized, by the way, Jessica, by the APA as a formal therapy. I think it eventually will be, given that MDMA and psilocybin will eventually get online in the next few years. Hopefully, fingers crossed. I mean, we've waited too long. These things are life-saving things, and they are so low risk that it is time that we demanded something that is useful. But we've got to play the game. We have to do this right. We've got to get the science. We have to ensure the public that is skeptical about this that, listen, this is safe. We're going to do this in a sort of methodical way. Just we've got these intelligent and ethical researchers like yourself, Jessica, and people out in Hopkins and NYU and San Francisco and so forth that are doing this correctly. So we have to be respectful of how to do that. But there are diploma programs through the CIIS. MAPS, of course, if you have some training, I think there is a program that you can do, but really that's about it that I know of. There's nothing that is formalized education for that. I know that Jeff Gus at NYU might be doing something like that with Ingmar Gorman and someone else. I can't remember, but I think they're trying to create some sort of a curriculum, and you can speak more to that, and then I can answer the second part of the question, which was whether a psychedelic therapist should have an experience to fully appreciate the panoply of what's happening. Yeah.
Oh, I would just say, yeah, so that it was formerly the Center for Optimal Living. So Ingmar Gorman and Elizabeth Nielson, they formed a new company called Fluence, but they are still running the same courses that they did at the Center for Optimal Living, which is like a Psychedelics 101 and 102 for clinicians, which isn't really like training to be psychedelic therapists. It's more how to help patients prepare and integrate surrounding an experience without kind of risking their license.
Right.
Because it's kind of tricky right now on how you navigate that and what risks go to your license and what you can safely do. I know there's a lot of anxiety around that for therapists that want to help in some way, but they're just unsure of this kind of murky legal situation of what they can and can't do without getting audited by their license board.
Right. You make a good point. I mean, we have to be respectful. This stuff is Schedule 1. That means it's illegal. So you have to be very careful about, you just have to be careful. You just have to follow the rules, essentially. I mean, that's all I can tell you. I can't tell you anything more than that. I hope and pray that when these things come online, that there's a formalized program, and there will be. And I think that the people that go towards this line of work should be very aware that it isn't going to be easy work. Remember that these psychedelic trips that have been done in research centers, respected research centers and so forth, they last 5-6 hours. Okay, so you're spending 5, 6, 7, 8 hours a day with one person, maybe two sitters with one person, completely focused on their well-being, not only from a safety issue and environmental issue, but their psychological well-being. So you have to be on your toes for 8 hours. I mean, that's hard to do. So I'm just going to tell you, you're doing invasive brain surgery without using any scalpels. So you better be focused, okay? So one, you have to be disciplined and focused in this, because you owe it to the person. That person that's experiencing this is vulnerable, and your heart should be in there 100%, because people can feel disingenuous people and people that are out that are not in the right space. If you're not having a good day, they may not have a good day, and that's you can't do that. So you need to know yourself. So I think psychotherapists and therapists that eventually do this should probably have their own undergo their own psychotherapy to know their own blind spots, to be able to make sure that whatever comes up in these sessions with people, they're not bringing their own countertransference to that particular thing. Countertransference is a fancy word in psychiatry or analysis of saying, what is the psychiatrist or analyst baggage that is happening between the patient and the therapist, okay? But so I think a therapist needs to be psychologically sound in mind. Any giver or a healer should have healed their own wounds, if you will, or be in the process of healing their own wounds before they're able to heal the wounds of other people, because it just makes sense that way. But to answer your question, and no one's perfect. Listen, I mean, no one's perfect. I mean, I'm not saying that there aren't people out there that are doing wonderful work. They still don't have their own traumas. I'm not getting to that point. I'm not saying that. I'm saying that the person, the most important person in that room when someone's having a trip is that person, and you have to make sure that that is your number one priority. Now, how do you know why that would be so important? Because I think that psychedelic experiences are ineffable. And the word describes a way of saying you cannot describe it in words. It's indescribable. So how do you describe to people what they may have experienced if you haven't probably experienced yourself to a certain degree? That doesn't mean you couldn't do it without having experienced it, but I probably think the MAPS organization does allow people legally to have an MDMA session so they can experience what their patients may particularly have. I think it's a smart idea. I think it's a smart idea to do that as long as you're vetting the right people. So do you have to do it? Probably not, because there are certain rules and things that you do in these sessions, as you know, reading the literature on sitters and so forth, is that you're sort of just kind of keeping an eye, but being engaged, but not being too engaged, sort of a distanced connection with the individual. So, does an oncologist need to have chemotherapy to treat cancer? Their answer is no, but they may better be able to understand the damn side effects of chemotherapy if they had it themselves. And if they're going to, be really aggressive with things, they may understand what a patient that's undergoing chemotherapy may experience, so they can take it. They have that sensitivity to that person. But I don't think it's a fixed no. But I think if they can, it would enhance the experience for the person.
Yeah, thank you. I know it's a pretty polarizing topic right now among the emerging psychedelic therapy fields, where people don't think it's necessary and others think it's absolutely necessary, because how could you possibly understand? And it's a good analogy with some of these other therapies like chemo, where, or like, every drug that you study as a psychiatrist, you don't need to take it and sample it to understand what it's doing. You study the pharmacology, you understand it sort of academically.
Yeah.
But you don't necessarily need to understand experientially. But I think something unique about psychedelics is that, there's something about the experience that is unique. It's not potentially just pharmacological. There's something embedded in the experience that I think it really helps to have that understanding of that kind of altered state of consciousness. But with the MAPS therapy training, you know, they do require everyone to go through some aspect of an altered state of consciousness and be sat for, and that's kind of, you know, they take turns doing the different roles. They do give people the option to do holotropic breathwork instead, which, you know, is able to pretty reliably induce an altered state of consciousness that some of the people claim feels a little euphoric like MDMA, but not exactly the same.
Sure.
And I know that like psychotherapists do actually have to do a little bit of their own therapy while they're training. So it's kind of like an interesting approach. And I'm just curious what your thoughts are if once the APA can accept these things, if we would then have accredited training programs where they would take this into consideration. And what do you think would be needed to convince accredited training programs to have experience as part of the training?
Safety, number one.
Okay.
Safety. Once you have established that it's safe to do, then you could proceed with the rest are details. You will not be able to convince anyone, and the utility of it too. If it's safe, you know, it's a risk profile, right? If it's unsafe, you're not going to be able to get to do it. But if you can convince that it's safe, you're going to be able to get to do it. Okay, you've crossed that hurdle. Well, what's next? Is it useful for you to have to do it? If you can convince yes, then you have more evidence that that's useful and you can incorporate it. If it's not useful, then what's the point anyways, right? So I think that you first have to convince people on anything that things are safe or not safe. You got to be honest. You know, you don't want to. You never want to be pushy with people. It doesn't work out. They're defensive, understandably so, because you're being pushy. So you just have to say, here's the facts. This is safe. It's not toxic. We have trained people that know how to do this, and this will reliably increase the chances of this experience being even better for the person. Now, Jessica, I don't know if we've done studies on that yet, whether we looked at, and there you go, there's another study right there.
Well, that's what I was going to say is that, you know, we could do a study once this is approved, or even you could just have like a treatment study enrolled where you also treat the therapist, one group of therapists, one group doesn't get the training, and then you see if it helps the efficacy of how they can implement their therapy.
Yeah, this is a growing field. I mean, there's the possibilities are, Chris, the possibilities are endless with what's going on right now. And we're itching to get this going because we know the potential of these things. But we have to understand that there is a lot of it this is an iceberg, and it takes a lot of energy to push that iceberg along, right? To get that initial activation of energy. But once the train starts to leave the station and people start understanding how this can be helpful for them, they're not going to want to go back, you know? And I think you have to do it safely first. I mean, you have to do it safely no matter what, but that's the reason why you want to do this safely. It's safe, but you want to do this in a very controlled way, because then you get to tell the community, hey, listen, we did this back in the 50s and 60s. People ran away with it, but you know, we're bringing it back because we need it in this world. There's a lot of trauma in this world. You may not see it outwardly, but there's a lot of trauma in this world, and we're holding on to it. We're holding on to the trauma right now. Although I would argue that right now during this pandemic, people are coming out and they're getting connected with the world again. They're starting to go outside and play outside. They're smelling the wonderful, you know, leaves rather than the smog, and they're starting to understand, why do I work so damn much? You know, all that. But we have to be measured in our approach and say, we've done the work. This is really useful. We need it now because of how much help people need. And here's another thing I would say. Look at the first responders in this COVID pandemic right now. I'm working at the hospital, HCMC. I see the ICU nurses and doctors, and they have not seen this much death in a long time. I don't want to scare any people, but I'm just saying, like, this is a real deal. And they're going through things that are very, very traumatizing. Look at our ER doctors, look at our paramedics, look at our first responders in other places. They are prime candidates for experiencing things like MDMA to sort of reset their trauma system, because you don't want them burning out. You don't want them leaving the field of medicine because of this, or struggling because they're trying to save a person's life. So, I mean, here's a perfect opportunity where MAPS can kind of come in and go, hey, maybe we should write a letter to Rick Doblin. And I'm being serious about this. I'm being very serious. And say, listen, let's open this up. We'll open up a MAPS center and treat our local physicians and nurses and ICU responders. And let's get this going and see what happens. Right?
That's a great point. Actually, there's another physician in the group that was proposing this a couple months ago, kind of before all this stuff was going nuts, but just kind of thinking about how so many physicians are burnt out, they're in debt, they've got severe depression from, going through medical school is kind of traumatizing. And how can they be effective healers if they're dealing with all that baggage? And so like conducting a study, as you're saying, where we actually use either MDMA or some psychedelics to help treat them, and then hopefully that'll change their perceptions and how they treat their patients potentially.
Well, you do two things, I think. One, if they are not being traumatized, and if they're not burned out, and if they're not depressed, that's one thing. You've helped that person. But if the outcome is you have these doctors and nurses that come out and say, hey, I'm a doctor, I'm a nurse, these things are safe, and hell yeah, we want this to be even more. We want other people to have these experiences. I want my patient. Let's say I'm a primary care physician, and I know my patients who's dealing with trauma right now that could really use this. You create advocates for something like this, because that's how much I'm convinced of the utility of these tools to help people, because this is infectious. If it gets into the hands of the right people, that's the real virus right there. You know what I'm saying? We need to get this going, but you've got to get it to the right people, and you have to have the right funding, but it may be the right time for it. But I'll help you write that letter, Jessica, if you want.
I mean, that would be an interesting study. I know the university's fast tracking COVID related stuff, and they're doing other kind of telehealth related support for physicians and other healthcare workers on the front line. But whether like we could do something with MDMA or something and get MAPS to fund it.
Absolutely.
That would be really interesting.
Totally. I'm on board. Let's make it happen, All
right. So I want to close out with maybe one less clinical question. Maybe it's a little bit more scientific. It's related to near-death experiences, and maybe also you could touch on sleep paralysis. I don't know if there's kind of similar mechanisms there, but what do you think about that and DMT release that might be involved in that?
Yeah. No worries. So again, so we alluded to DMT maybe being secreted during REM sleep, and it's really not DMT. And again, how do we know? We don't have any sort of measurements to be able to measure DMT in vivo during dream sleep to be able to do that. We've been able to do this in mouse models and things like that, but it's mostly acetylcholine. So I don't really know much about the near-death experience literature. I think it is fascinating. I think that it's doing what it's like, to a certain extent, it's creating a non-ordinary state of consciousness, and whatever that may be, it's maybe different than what happens in a traditional 5-HT2A receptor agonist mediated psychedelic experience. But sleep paralysis is a different beast altogether. And I love talking about sleep paralysis because it's so weird and interesting and so non-harmful. I just want to say that out right now. Remember when we were talking about non-REM sleep and REM sleep? And in REM sleep, we tend to dream our most vivid dreams, and we're dreaming in Technicolor. Also in REM sleep, our anti-gravity muscles are paralyzed, meaning your arms are paralyzed, your legs are paralyzed, and for good reason, right? Because what would happen if we were not paralyzed, our muscles weren't paralyzed when we were dreaming? We would act out our dreams. We would punch our aggressor. We would run away from the animals or whatever. And there's a condition called REM sleep behavior disorder that is exactly that. And that was actually discovered at Hennepin County Medical Center at the Sleep Center by Dr. Carlos Schenk and Dr. Mark Mahowald, who unfortunately passed away just a month ago. He was a wonderful teacher, just a wonderful mentor and teacher. And Dr. Schenk, I still work with him, but they discovered this disorder, and I'll talk about that in just a second. But in REM sleep, not only are you dreaming, but you've got this paralysis of your muscles. What happens in sleep paralysis is you're in REM sleep. Remember, you're kind of offline to a certain extent. You may be dreaming, but something happens where the state of sleep and state of REM sleep and the state of being awake get superimposed. And you have an overlap of being your body being still asleep in REM sleep and your mind being awake. So you become consciously aware that you know you're awake, but your body is still asleep. You're still in REM sleep. There's residue of REM sleep sort of lingering on, and you can't move. That's terrifying, okay? You feel like you're paralyzed. Some people will describe that they have a pressure on their chest because their diaphragm is the only thing that's sort of moving to be able to breathe. The other accessory muscles, the intercostals, the scalenes, the sternocleidomastoids, these other muscles are not engaging because they're paralyzed. And so it feels like it's harder to breathe, because it is to a certain degree, because you're trying to do more than you can at that moment. And because you've just come out of REM sleep, which I said, remember, it has these hallucinatory experiences like dreams. Some people may actually see shadows in the background. They may feel a presence in the distance. They may, some of these alien abduction stories, or actually could be these very fantastical sleep-related hallucinations. So sleep paralysis is just a residue of REM sleep intruding onto wake. There's nothing wrong with people. The majority of people that have sleep paralysis are either sleep deprived, or they may just be wired where they've got this overlap of sleep paralysis and wake. Those are interesting people to study. But it does not have any, it doesn't portend any sort of bad things. Now, RBD, on the other hand, REM sleep behavior disorder, that condition where the switch that turns the muscles off when we're in REM sleep, that normally turns the muscles off during REM sleep, that switch is broken. And now you get to act out your dreams, which is not a good thing, because people, get injured and they fall out of bed because they're acting out their dreams. And lo and behold, you follow what's happening is the RBD, Dr. Schenk and Mahowald follow these people for about 5 or 6 years. The seminal paper was published in 1986, but the first case was Carlos Schenk's first patient at the sleep center. And they figured out that there was this connection. But RBD is actually interesting because if you do have it, 80 to 90% of people that have it go on to have what's called a synucleopathy, a neurodegenerative disorder like Parkinson's disorder, multiple system atrophy, or dementia with Lewy bodies. Now, I don't want to scare anyone if they're doing it, because these things are probably more common in the population than we know of. So isolated dream enactment behavior could be completely normal. But RBD, what we call idiopathic RBD, is not normal, and you should see a doctor about that, a sleep doctor about that. I can't add too much more, Jessica, about the near-death experiences, and not a lot of people know significantly a lot more, because you only have a few cases, right? You have only a few cases to work with. Only to say that, man, when your body is in some sort of a stressed mood, or you can experience these things. There's these release of certain neurotransmitters. That's all I got.
Awesome, thanks. I think one final closing question
Sure.
I had.
Yeah.
I wrote it down because I thought it might be an interesting integration strategy. I wrote down sleep as integration, because you were talking about how, we use sleep to consolidate information and process memories and whatnot, and also to, kind of dissolve a little bit and then come back together. And I thought that was interesting, because it seems to be a lot of what, we think about when we think about integration, and sort of making sure you get a good night's sleep after you take a trip, or thinking of various sleep practices as, making sure you're incorporating that into your integration. And if you think that could be sufficient for some people, or if we kind of need these additional steps of journaling and whatnot, to process what insights have come up during a psychedelic experience.
Yeah, no, absolutely. I think it's yes, and it's I think that you could initially just kind of have people keep sleep journals beforehand to see whether they're chronically sleep deprived, and then see what happens during the experience to see whether there's a comparison between people that are not sleep deprived versus sleep deprived and those outcomes. As a retrospective study, or as you're accumulating data. That's why maybe having these questionnaires could be so somewhat helpful if you have a big enough pool. But then you might create prospective trials on the role of sleep in these particular experiences and how sleep deprivation could change it one way or another, because it likely will change it one way or another. And then I'm glad you touched on this, that we are thinking when we sleep. Maybe we've all had, when we woke up, we go, oh, I think you sometimes occasionally have an aha moment. And they're rare, but they do happen. And in these psychedelic experiences, the aha moments happen way more often. That's why they're so, useful. And the Benzene Ring, by the way, did you know that the Benzene Ring was discovered by a person that was dreaming about a snake that was biting its own tail? So it made a circle. So they figured out the structure of benzene while they were dreaming. Dreaming is just a playground for creativity. It's letting the ego get out of the way. Get out of the way, ego. Let me play with my mental creativity. And you come up to more solutions when you have more sort of variables, right? But too many variables all at once make you inefficient, which is why our brains are tuned to think a certain way, because we're efficient that way. You don't want to be in a psychedelic state all the time. You would be disorganized. You wouldn't get anything done, It doesn't make sense.
Awesome. Thank you for that. Well, so we're about out of time. Do you have any last parting words of wisdom for us before we sign off?
Just a lot of gratitude. Thank you very much for doing this and hosting this. And I'm really honored to be part of this project, this mechanistic study using psilocybin in surround suppression. I think that this is the beginning of just some awesome things down the pipeline. And I hope and pray that, I really do. I hope and pray that this is available to people, because I know genuinely that it's time. The people are suffering, and we need to get this into the hands of people and do this right. So
Great.
I really appreciate everyone that signed on and listened to my ranting and raving, but it was fun. Thanks, Chris.
Yeah, great. Thank you so much.
Thanks
so much for joining us.
Thanks, guys. Oh,
Have a good
absolutely.
night.
Absolutely. Bye-bye. Take care.
Bye.